Welcome to Talking Tech Journeys, hosted by me, Ben Whiteley of BPM Tech. We're delighted to bring you season 1 of Talking Tech Journeys. The aim is clear, to bring you some of the most engaging and respected figures within tech and transformation, providing a snapshot of their journeys to share knowledge, ideas and insights on all things tech and transformation. Sit back, relax and enjoy the journey. Welcome to Talking Tech Journeys. I'm Ben Whiteley and I'm delighted to be joined by Haroon Taylor, CTO of YewMaker, company building science-based solutions to make healthcare good for people, planet and prosperity. Haroon is a data scientist and recent Healthtech CTO with experience building scalable and systematic data solutions to solve problems in healthcare with a particular focus on data visualization and scientific communication. Hi, Haroon. How are things?
I'm good, thanks. How are you, Ben?
Good. Yeah, looking forward to getting stuck in and finding more about your journey and background, and like say where you are today as a Healthtech CTO. So yeah, let's start from the beginning then. So how, why, and when did you first become interested in technology and health technology specifically?
Yeah, so going back to my childhood, I was always quite interested in healthcare. Both my parents are NHS doctors by background, always lent more towards science and mathematics at school. And then from the technology angle at university, while studying natural sciences, I had a fantastic opportunity to do a year in industry as part of my degree. Where I worked at this Oxford-based startup called Genomics PLC. The term data scientist wasn't around at that time, so my job was a bioinformatician. And essentially, I was writing code to integrate genome-wide association studies into their internal company pipeline. So I was like at the very start integrating these academic studies mainly. And the genome-wide association studies, they take a large group of people, sequence their DNA or genome, and then look at small variations in that and associate them with common diseases. And essentially what that meant was I had to handle lots and lots of data, like millions and millions of rows.
Wow.
I remember my first week, I tried to naively load a data set and my computer instantly crashed.
Yeah.
So I sort of learned the hard way, like how to integrate all of this complicated healthcare related data in massive amounts of data. And I think that was when I found it really hard and it was really challenging and I like to challenge myself. So that was something where I was like, oh, this is quite interesting. So I was remember like reading up on it, actually like outside of doing the work. And that was a novel experience for me at the time. Two, I just sort of saw the power that data science could have as this like data was exploding, and that happened in genomics about I don't know 5-10 years ago, where we had this explosion of data. We could sequence everyone's DNA suddenly, but we didn't know how to analyze that and how to harness the computational power of it.
Yeah, well, it's great. Obviously, like I say, data science is very much an evolving field and something that can shed a light on sort of throughout the conversation. So like you say, no doubt some mistakes, challenges, I mean, sort of anything to sort of take away from that sort of first job?
Yeah, I think it was all right to make mistakes. And also, I think working in a startup really helped me like understand that was a culture it was a really good fit for me. It was just lucky that it was my first job. So I think the things that some people can find stressful with like the fast pace, the continual uncertainty, I like really enjoyed that and really thrived to try and like do more and more multitask, that kind of thing. So that really helps me. And then just understanding that it was all right. People like, also in a startup, you don't always know what you're doing. You just have this goal and you're trying to get there. And that was like, again, quite refreshing for me to understand at that point in my career.
And then you've subsequently sort of moved on to a couple of other positions, sort of health navigator, HN, sort of, using AI and predict and prevent sort of care need. I mean, and then Department of Health and Social Care. So how was that as an experience?
Yeah, so I did a master's in computational biology. where essentially I was taking papers again and trying to write code to recreate the analysis. After that, I wanted to come into healthcare, but at the time, the healthcare was a bit, there were less roles available in healthcare, so you needed more experience. So I ended up actually working in football analytics for 2 years, again at a startup, but this gave me like, I managed to like increase my ability to code in lots of different languages a lot. Then I came back into healthcare at Health Navigator, and that showed me how I think I learned a little bit at all of these jobs. And in Health Navigator, it was definitely the frustrations of regulation in healthcare. And like I was younger, I wanted to like move quickly, and there was a lot of heavy regulations. Health Navigator was using this AI model to try and identify which patients were most at risk of extra bed days, and then give them clinical coaching to try and avoid it. And essentially what we're saying is 80-year-olds need to have some system so they don't go back into hospital. But we're trying to apply this AI model to it, which was quite nice and innovative, but it was a real struggle to get people to want to apply that and have the money to apply it in the NHS. Then I had again very lucky opportunity to move and work on the COVID response modeling for the Department of Health and Social Care as a contractor. And there I really saw what was possible when it needed to be done in healthcare. So I had access to lots of different data. So again, I was creating an infectious disease model based on mobility data from around the country to see how variants would spread in the country. And normally you would never have any access to this kind of data, but because it was immediate, we were trying to do something with COVID. A lot of things in COVID time got accelerated. Sometimes that was maybe bad, but in some cases that was really helpful to like accelerate the technology to help us like understand these things. So that was really exciting for me to be able to have access to all this data and be able to apply it quickly in the Department of Health and Social Care. So whilst the Department of Health and Social Care is a massive company, it was also kind of operating like a startup in COVID times in a way. Like they were trying to change very quickly and adapt to this very quickly changing health crisis.
Well, like say, critical work in a real sort of difficult time. So, you mentioned sort of some of the challenges. I mean, how did the health social care how did it sort of adapt during that time you were there?
So practically, they hired lots of contractors, and they've reached out to a lot of like the best academics in the world to try and understand and get their knowledge. And then also they changed like a lot of their systems and their databases to be able to incorporate all of this large amount of data as well. So they started using rather than you using your local computer machine, they also started having machines that you could access in the cloud, so you could do the analysis from anywhere and making those readily available, this kind of thing, which sort of just sped up the process and see how the power of technology can help you.
And like you touched on from the offset, data science is constantly evolving. I mean, from your sort of life experience and people that you've worked with and mentors, etc., what attributes, in your opinion, make a great data scientist?
Yeah, I think so. Firstly, you do need a good understanding of applied statistics and coding, but probably not as much as a barrier as people think. Like you can go on coding courses now, learn how to code, like I wasn't actually particularly good at statistics when I was younger. Like I always got confused around probabilities, but like if you try and learn these things, you can. I think beyond that, it's an inquisitiveness. So rather than, I'd say a very simplistic way of looking at the difference between a software developer and a data scientist is the software developer asks, what model are we building today? And the data scientist asks, why are we building this model? So you sort of need to think, what is the reasons behind with us doing this sort of technical task? And then also, I mean, it's key in a lot of roles, but communication, and specifically, you're constantly translating between a non-technical and a technical audience. You're like that go-between between those two worlds.
Yeah, which I think will sort of, is a really valid point. And sort of, a big challenge for a lot of health and social care sort of settings, which I think we'll sort of talk about a bit later on in the podcast, if that's okay. So let's fast forward to 2022. You joined another tech startup, YewMaker, as senior data scientist, and recently been promoted to CTO. So congratulations. But in terms of, what was the appeal to a startup, and who are YewMaker?
Yeah, so as I mentioned before, I think I've always worked in sort of a startup culture, even though it's been for different sizes of organizations. So that felt very comfortable for me. I hadn't worked in sustainability before, but I'd always thought the social context of my role, I always thought that was quite important. And I felt like the climate crisis, all these things were becoming a big issue, and also something where there wasn't a light being necessarily being shined on it in healthcare. So that also attracted me towards that. And then so YewMaker we're a small startup. We're based in London, but we also have an international focus. We work in US, EU, and UK health systems. And we build science-based solutions to make healthcare good for people, planet, and prosperity. We sort of do this through 3 different functions: policy and thought leadership to drive culture, partnerships to drive change, and that's through the Sustainable Medicine Partnership, and products to drive action, and that's through mainly the Medicine Carbon Footprint Classifier.
Yeah, I mean, as I've said to you previously, and there seems to be quite a bit of renewed hope in the new government, bringing fresh ideas, impetus, energy, lots of talk and noise regarding, but it seems to be more focused on sort of historical issues, the aging population, waiting lists, staff burnout, recruitment issues, underpinned by and driven by digital transformation, innovation, digital wards, AI, saving time, money, and driving patient care, but not so much focus on waste, environment, existing supply chain, manufacturer to distributor, provider of prescriptions, pharmacy to patient. But I suppose that's where you guys sort of come in. So how, I know there's a lot of, talk in your world. What is the sort of value that you are bringing to healthcare?
Yeah, so we're all about driving action and making practical changes. And I think a lot of in sustainability in general, but also in the healthcare space, with all of those things that you discussed, which are very important and sort of immediate concerns, it feels like it's a hard place to start. Like, people don't know where to start. Like they if you ask the average person, they think that sustainability, climate crisis is a problem, but they're not really sure what to do about it. So we're sort of there to bring practical solutions. So that's why one of the reasons we set up the Sustainable Medicines Partnership, which is a group of 48 organizations, a diverse set of, with a common goal to reduce the waste of medicines and the waste from medicines. And it spans across the whole healthcare ecosystem, has pharma, generic and retail manufacturers, distributors, healthcare providers, innovators, researchers, policymakers. So it was really a space where people who wanted to do something about sustainability in healthcare could collaborate. And one of the outputs of that has been the Reducing Wasted Medicines Playbook. The every dose used.
Yeah, that's it. Yeah. Which I was sort of going to sort of mention in terms of, I know it's recently been published, but just for the sort of viewers and high level sort of summary, what are the sort of key findings, in terms of patient care, cost, and the environmental factors?
Yeah, so the key findings is that there are millions of ready to use medicines which are never used because of many issues across the medicine supply chain. And it sort of gives some idea of those problems, how they might affect your company and the solutions to those, and sort of the level of solutions. So things that you can do now, things that are going to require collaboration, and things that are going to, that require lots and lots of different stakeholders to be involved. And yeah, just highlighting those areas in a way that doesn't feel so pessimistic, but more optimistic in a way that we can actually, this is a problem, but it's a problem that we can solve. And also, I think when you think of wasted medicines as a patient, you see this end of it, but there's lots of all the way through the supply chains where there's lots of inefficiencies.
And like we sort of touched on off air, you know, the NHS is committed to, well, being net zero by 2040. So lots and lots of work to be done. And like I say, it's all about action. So let's just sort of take you back to the medicine carbon footprint, because I know you've been heavily involved with that. Take you back to the beginning then. How and where do you sort of start estimating carbon emissions and the actual footprint of you know, the medicine carbon footprint? Where do you start?
Yeah, so I mean, one of the only people I know who ask more why questions than me is our CEO, Nazni Rahman.
Right.
And it started with her saying, oh, we could do this. We could estimate emissions from, I think one of the initial ideas was from patents. And I was like, no, you can't do that. That's not going to work. And then we discussed it a bit more and we were like, okay, how can we do this? Because at the moment, there are two solutions. One of them is very, very detailed analyses, which is called life cycle assessments, where you basically, you break down, and it can be anything, but here we're talking about manufacturing medicines into all its constituent parts. So this amount of gas was used here, this amount of transport was used in this bit. And then you try and assign emissions to each one of those bits, add them all up and get the emissions of the whole life cycle. And those can be like really detailed as they are by their nature, but in very difficult, very time consuming and costly, and also very difficult to compare because everyone does them in a different way. There's not a standardized framework at the moment. And then on the other end,
to scale as well.
Yeah, incredibly difficult to scale. Like you can do it for one of your products, but say you're a company who has 10 different suppliers, trying to reach out to those suppliers to do it for all these different products. You're sort of going back to first principles with something that's you've done before but not considered this angle. And then on the other end, you have these environmentally extended input-output models, which in the most basic way, you can think that you take a factor, an emissions factor, which says for all pharmaceutical products, you have 0.2, or let's say 1 gram of carbon emissions per gram, per pound spent, or actually it's normally in kilograms, 1 kilogram of carbon emissions per pound spent. And then you take how much you spent on it, and then you times it by that factor to get what your carbon emissions were. And so that's very, very high level. So we were trying to look for something, what can be done specifically in the medicines area to somewhere in between that, which is what we called a middle out, but sort of a secondary data lifecycle assessment.
Yeah. So put a bit of context in. I mean, I think I'm right in saying that sort of the medicine carbon footprint accounts for sort of 25% of the NHS, you know, greenhouse gas emissions. So obviously a real priority sort of area to focus in terms of, you know, these net zero strategies and the environment. But with such a sort of variety of medicines, how do you sort of scale in a standardized way? I know you've touched on the different approach there somewhat, but how do you sort of standardize and so it creates meaningful data results and findings?
Yeah, so that was the real challenge. And yeah, like you mentioned there, medicine supply chain take up 25% of the entire NHS emissions, and the NHS emissions is something like 4% of the whole UK emissions, I think.
Wow.
Can't quite remember. Don't quote me on that number, but it's something like that. And so, yeah, it's a really big deal. And it's a massive black box at the moment. So our idea was to take the active pharmaceutical ingredient, so the bit that, a side note to that, there's a lot of jargon in data science and there's a lot of jargon in healthcare. So, and one of the key things, which every single day almost, I'm talking about APIs. APIs in data science means application programming interface. So it's a way to, and APIs in healthcare means active pharmaceutical ingredient. So a very common issue.
An API in tech means something totally different.
Totally different to healthcare, basically. But yeah, in this context, API, active pharmaceutical ingredient, bit that makes the drug effective. And so the structure of that API can be used to determine how difficult it was to make. And the more difficult it is to make, the higher carbon emissions it has. So we basically used lots of research from process chemistry, which is about 20 years of research, and applied that to currently used medicines today to get an estimate. And what we're looking for here is it's a practical and a data science approach. I would say those two are synonymous here, which is we're not looking to have something perfect, but something that's better than the incumbent. So if we can push the needle forward, we can show action and show people what's possible.
And you've sort of created a RAG model. I mean, are you able to just sort of discuss and, just elaborate a bit further on the actual solution and platform?
Yeah, so the medicine carbon footprint classifier or MCF classifier and the MCF model estimates carbon emissions of medicines. And then with funding from the Small Business Research Initiative, we built the MCF Formulary, which is a use case specific look on that data, which integrates with the British National Formulary, which is how healthcare practitioners in the UK look at their medicines, and integrates that into the MCF. So in the MCF Formulary, you can search for a medicine and see its traffic light style or RAG rating on a low, medium, high, very high emissions, which just makes it's an accessible educational tool for healthcare practitioners to start to think about and compare the carbon footprints of medicines.
So, I mean, to conclude and wrap all this up, what sort of outcomes can we see in terms of, I don't know, unnecessary prescriptions, wastage of, like say, drugs, carbon effectiveness? Where does it all land? What are the sort of the benefits and findings of all this?
Yeah, so one of the great opportunities of doing this data science approach is that it was comparable across all the medicines. So we did an analysis across all medicines and found that antibiotics as a category produced a significant proportion of the emissions. And this also aligns very well with antimicrobial resistance and the fact that 20% of antibiotics are unnecessarily prescribed. So now we can add this extra layer of carbon emissions to say that if these antibiotics, which people agree should be deprescribed, were deprescribed, how much carbon can we save? And it turns out that it's a lot.
Right. Talking, lots and lots, no doubt. And I suppose, like I say, with antibiotics, it resonates with a lot of people because probably pretty cost effective, but, very high volume in terms of prescriptions.
Yeah, lots of prescriptions, lots of potential for changes, lots of things that are just the norm that have been done because they've been done for a long time. Like there's a switch from, so for instance, lots of GPs will prescribe 7-day courses, but there's lots of evidence to show that 5-day courses are enough. So 7-day courses is 3 tablets a day for 7 days. So you're saving 5 tablets just for each course you're doing. And there's so many of these that are prescribed, and that's a massive carbon saving if you can reduce those.
Well, I can imagine, like I say, the cost implications as well, no doubt.
Yeah.
Good. So, I mean, obviously a bit more general in terms of, your world, data science. I'm keen just to explore, your thoughts on sort of what opportunities do you see within health and social care, and how sort of can we capitalize on using new and emerging technologies?
I think there's lots of opportunities at the moment, particularly around the large language models like ChatGPT style models, where you can see that I think they're going to be used increasingly in healthcare, but there has to be safe and ethical ways to use those, particularly around what is the original source of the data. And as we can solve those things, again, like as I saw in genomics, where we had this data science or analysis could analyze this level of data, we can also now analyze this messy like language data. And if we can do that, I think that's going to unlock the potential for lots of solutions in healthcare.
What sort of time frame? I mean, that sounds as though, like I said, there's going to be lots and lots of source and different feeds. I mean, how do you go about that? Is that even possible?
Yeah, I mean, the time frame is difficult. There's lots of regulations in healthcare, as there should be, and safety concerns, which sort of increase the timeframes, but people are doing things with them now. So yeah, I think there are ways to, for instance, patient information leaflets. For a long time, they've always come in the packaging, and there's no digital copy of them, and also they're not even in a way they're not easily to translate. They're also not very identifiable with patients. They still have lots of medical jargon. So if we can have a digital version of those, which then whatever country you're in, you can get it in the language you want. You can get a version that's that kids can understand. These kind of things. That's stuff that can be unlocked.
Yeah, which, like I say, are very important for the future. So, I mean, look, Haroon, many thanks for your time. It's been great exploring your journey. Best of luck for the future, and yeah, it's been great to get an insight into data scientists in health and social care.
Yeah, great to talk to you.
Thanks for that. Just lastly, to the listeners, it'd be great to hear your views on the evolving role of data science in health and social care, and your thoughts on the importance and strategies in reducing greenhouse gas emissions and working towards the NHS net zero target by 2040. Thanks for listening.